Hi, everyone. Can you hear me? Okay. So thanks for the organizers for organizing such a nice conference. Today we're going to talk about the promise of predictive medicine. I figured what we do, since we only have a few minutes, very short time, we'll do a survey. So we'll do a very kind of shallow but broad approach. Okay, so little formulas, lots of pictures, and the idea is to show the many different types of applications of predictive algorithms in medicine. And medicine is not just medicine as we think about it. A lot of the talks today, very impressive talks that we've seen, have been around genomics, EHRs, looking at specific individuals. There are also populations and other aspects of medicine that I want to talk about. So let's get started. Everybody would love to have a crystal ball. Kadur bdolach, is that how you say it? Okay, you'd want to be able to tell the future. So if you had a crystal ball, you'd probably, a lot of people, when you ask them, what would you want to do with a crystal ball? They'd say, I'd want to play the stock market tomorrow morning or bet on sports games. So that's kind of their first go-to thing. They say, okay, now what else? After you've become very wealthy, what would you like the crystal ball for? And then people start scratching their head, and then you offer them, you say, would you like to know your medical future? And the interesting thing is that not everybody jumps at that opportunity. They don't all say, yes, I want to know when I'm going to get sick and when I'm going to die. And it's not as appealing as knowing who's going to win the game tomorrow. So the question is, what is predictive medicine and in what ways is it helpful? So let's talk a bit about that. Today, medicine is becoming ever more data-driven, and with the advancement of machine learning, we're able to apply ever more advanced methods to these data. One project that I'd like to talk about is the Intelligent Histories Project, which we started a few years ago now at Harvard. And it comes from the word medical history, right, that a doctor is supposed to take for a patient whenever the patient comes in. So the idea is, can we add intelligence to this history? And I went up to the head of our department, who happens to be a practicing emergency department doctor in Children's Hospital Boston, and I said, what condition is really hard for doctors to identify in the course of a clinical encounter, but a computer with kind of a broad view of the history might do a better job? And without batting an eyelash, he said domestic abuse, child abuse, hita'alelut, which is obviously a tragic condition. They say that abuse is an iceberg condition, which means about only 20%, some say 10%, is visible. In other words, is ever noticed, which means between 80 and 90% of cases of domestic abuse, tragically, are never discovered. And so the question is, can we use machine learning to help? Oftentimes, the very people who are perpetrating the abuse, the bad guys, are the very people who, at least officially in their societal roles, are the ones who are bringing the victim to medical care in the case of a parent-child or a spousal relationship. And so it gets very complicated to spot. A doctor, this is all fake data, by the way, a doctor trying to identify hidden signs of abuse might be faced with a screen like this, which is very much not helpful for someone to identify patterns. A machine, however, is very good at using those things. And we developed certain algorithms that were able to identify up to half of all cases of abuse, on average 2 years before they were detected. Now, in some cases, that means abuse is already going on, but it's undetected. And the system was able to identify 2 years before the doctors did. In other cases, it means that there might be a condition called pre-abuse, just like pre-diabetes, that perhaps physical abuse hadn't begun, but the signs are there, and you might even be able to prevent it. And we built a risk alert system around these kind of models. Sometimes the system was able to identify abuse up to 6 years in advance. There's some interesting philosophical questions here in the study design. What's the gold standard? What are your labels? If 80% of all abuse cases are never identified by the system, so if the system identifies someone with a very high score, and then you see what happened to that person, and you say, oh, they were never diagnosed with abuse, is that a false positive, or is that an undiagnosed condition? There was a whole bunch of extra IRB stuff we had to do to make sure that we wouldn't end up identifying live cases of abuse, et cetera, et cetera. So there's a whole field there that tries to bridge the gap that the medical system currently inhibits certain diagnostic activities due to its structure. Okay, here's a quiz for the audience. What you see here is statistics for the last 100 years, 1917 to 2017. Whoever knows the answer, please don't guess. Whoever's guessing, please guess. So that way we'll guarantee you're guessing. Okay, so these are the leading causes of death over the last 100 years. We have stomach problems, pneumonia, tuberculosis, the good old-fashioned ways to die. And then there's this red line, which hasn't really gone down in the last 100 years. Would someone like to guess what that red line is? Say it again? Car accidents, okay. Medical error. Going once, going twice. Any other ideas? Say it again? Deaths of despair, okay. Suicide, okay, so the winners are these two ladies over here. Deaths of despair and suicide, that is indeed what that is. Suicide is still a leading cause of death and has not been addressed. A, because it's not necessarily as biomolecularly tractable as these other conditions, but B, because of certain taboos around trying to address suicide. It is 100% preventable. We built models to look at different risk factors in the clinical records. And again, we were able to identify about half of all abuse cases, on average 3 years in advance. And now this system is being tested across different medical centers in the US. And we're trying to turn it into a downloadable app that can integrate with various medical record systems in use around the world. The idea being that doctors, even though they're supposed to look for signs of suicidality, in practice, rarely have the time to do so. Okay, so once we're on mental health, we also started looking at psychosis. Psychosis is a condition, it's a broad category of mental health diseases that are characterized by a loss of touch with reality. So schizophrenia is one type of psychosis. Those are very broad terms. It's actually much more complicated than that. Psychosis, however, is very hard to diagnose, especially when in its initial onset in the late teen years to early 20s. I don't know if you guys know any teenagers, but all the teenagers I know are having dramatic life events every couple hours. So when a teenager says, "Oh my God, I can't believe this is going to happen," that's called being a teenager. Funny or not, it actually makes identifying first episode psychosis very hard, because being a normal teenager and being psychotic is, on the surface, not very different. So all jokes aside, there's a serious problem where first episode psychosis is often undiagnosed for a few years. The duration of untreated psychosis on average can be as high as 3 years, and that's long enough for the situation to deteriorate enough that even if you start very effective treatment after those 3 years, you can never really bring the person back up to where they were as far as independence and level of self-function. And so there's a great interest to identify first episode psychosis much sooner instead of waiting for it. And so we were applying certain models now to do that, and with some degree of success. Briefly talk about some more projects here. Together with Clalit Research Institute, we have, for the past few years, we've been working on a project to improve medical risk prediction for the individual in the context of that individual's family. I don't know if you've noticed, but we're living in 2021, and many places around the world started using electronic medical records sometime in the 90s, and if not, then in the early 2000s, which means that we, our kids or parents, and in many cases our grandparents, now have about 2 decades, at least, of medical records somewhere. In Israel, because of the structure of the medical system here, family groups tend to cluster within the health organizations, within the kupot, and so somewhere, grandma and auntie and uncle and dad and sister and cousins, many of them are in the same medical record system. And the idea is, if you can consent everybody and get the agreement, can you use that familial information that's embedded in the EHRs without genomic sequencing, without now going and interviewing everybody, but a data-driven family history? And what we found, it's not really surprising, what we found is that yes, family information stored in regular EHRs can be useful for improving individual risk prediction, and we're calling it data-driven family histories. And it can apply to a host of different conditions, especially the chronic ones where you want that perspective of years to identify familial risk. Now, please note, this is not necessarily encoded in the genetic layer. There have been many studies in recent years that say lifestyle is nature and nurture. Lifestyle is also a big determinant of health, and lifestyle is very much correlated with family relatedness, especially among siblings, first-generation parent-child groups. So this is not necessarily only for genetically mediated effects. Okay, we're going to switch now to talk about the population side of things. So this was a paper we published in PNAS a few years back. I don't know if you guys remember way back in 9/11. This is way long ago. There were these anthrax attacks in America. This white powder. Okay, and as a result, the United States has been focused on preventing bioterrorism with much greater focus since then. And the way they do that is they try to identify whether or not a bioterrorism attack has taken place by basically monitoring emergency rooms within urban areas to see if there's a sudden spike or increase in specific disease categories. And the problem with public health data of that sort is it's very noisy. And so we applied certain filters to this data, certain digital signal processing techniques, and found that we could kind of double the effectiveness of these detection systems and kind of increase the signal-to-noise ratio. We then ended up talking to a few of the Olympic organizing committees in recent years, and they said, okay, we have a problem. The problem is we're hosting the Summer Olympics, if it's in London or Beijing or wherever it is, and we're worried about one of the threats being a mass bioterrorism attack because it's such a big stage. There's a great incentive for bad actors to utilize it for negative purposes. And so he said, what we're going to do is we'd like to set up what's known as a syndromic surveillance system, which again just monitors the emergency rooms in the city. And as a background, as a kind of historical background, we're going to keep track of the year or two before the Olympics, what's kind of normal for this region, how many people get respiratory illnesses in the month of July, how many people have gastrointestinal illness. And then when the year of the Olympics comes, we're going to compare that to the historical baseline. Pretty straightforward. Problem is, as you probably are all thinking, the year of the Olympics is not a normal year. Millions of people come, a lot of people go away, the utilization of the health system is very different. So there was a real problem of the very minute you need the system the most, that's when the major shifts in base populations undermine your historical baselines. And so we came up with basically what we call a homeostatic approach to public health, where we didn't look at the absolute levels of illness, but we looked at the relationships between disease categories and the relationships between hospitals. And we identified some pretty robust patterns in the relationships between hospitals and disease categories that actually held up even despite large population shifts. And we were able to build what we call the epidemiological network of a certain urban area. And that allows us to kind of identify outliers in a much more robust way and also kind of robust to shocks. And we applied that also to drug safety. So another realm of medicine is the huge pharmaceutical industry. There are always a bunch, as we know with the coronavirus vaccine, and a lot of the hesitancy around it were concerns, not that there was any specific concern about the vaccine or the vaccines around the world, but that people said, well, it hasn't been tested for long enough. And inherent in that statement is an understanding that FDA approval, even if it takes 5 years or 1 year, is still not enough, and we have something called the post-marketing phase. In other words, phase 4 trials. In other words, once the medicine is actually out in the field, how is it doing? And we're now working with Clalit, with our partners at Clalit. We're honored to be part of their study. They're doing real-world data analyses of the vaccine in Israel as part of a phase 4 study. But there have been trials in the past where they've tried to identify drugs that made it through the FDA process but then ended up being identified as dangerous thereafter. And so we applied the same, what we called a pharmacoepidemiological network approach to identifying that. We were able to cut down detection times from years to months. And then we took this network idea and actually created a whole drugome network, basically taking all the known drugs, all the known side effects, and modeling it using a graph theory. And there was a very talented mathematician in our group who was kind of had a hammer and was looking for a nail. So we sat down on the first day and he said, what do you like to do? He says, graph theory. So we said, okay, and we're going to find something we can solve with graph theory. And we represented the entire drugome as a graph. And based only on graph theoretic properties, we were able to identify half of all unknown drug side effects that were discovered in the next 5 years, right? So we took data from 2000, whenever it was, 10, and said, okay, what can we determine just from the graph structure? And we were able to identify a lot of the missing edges there. And we did it for drug interactions as well. 2 more examples in the 2 minutes we have left. So another way you can use predictive algorithms in medicine is in the healthcare system itself. Hospitals now are very overloaded. There are very few hospitals that complain of not enough patients or too many empty beds, and this is a problem worldwide. as population scale, as healthcare develops. And so we developed something called prediction of patient placement, or POP, which a very talented Israeli student in our group in Boston, Yuval Barak-Koren, led. What this was able to do was identify people within a few minutes of their arrival at the emergency room to identify whether they're going to be admitted or not with very, very high accuracy. And that allows us to plan ahead as far as bed space for them a few hours later when they're admitted. And there's also kind of larger models that take place in the hospital itself. I'll finish with two little vignettes about coronavirus. So this year, a very talented undergraduate student at Harvard wanted to look at Google searches. And so there have already been many studies looking at, can you use Google searches for tracking pandemics? And the answer is yes. And there's all these kind of issues with doing that. But we try to go one level deeper. This is a paper published in Nature MPJ Digital Medicine just a few months ago. We wanted to see, can you track the actual course of illness of the disease, of which symptom happens to each person, in what order? Can you do that from the search data? And surprisingly, looking at 32 countries across 6 continents, we were able to identify the actual course of symptoms from the aggregate search data. And when we measured across 32 countries, the difference between, when does the symptom onset happen, when does the apnea or problems breathing happen, the number we ended up getting, 5.16 days, was within 5% of the reported medical literature. And we were able to derive it based on search data, prior to the publication date of some of these case reports that were coming out at the beginning of COVID. So it's a kind of a new use for search engine data where you can actually derive the actual course of illness. And finally, I know this was up early in the morning, but I want to just thank our partners at Clalit Research Institute for this great opportunity to work with them. Really a dream team to work with everyone here on the coronavirus vaccine research here in Israel. You guys have, I'll skip all this, you guys have seen this morning, but we're going to skip to the last slide. And there we are. Okay, so in summary, predictive medicine is not just clinical risk prediction, it's not just genetics, and it's also not just EHRs. Every aspect of medicine is now undergoing a revolution where big data and machine learning are having tremendous impact. Whoever's in this field now is very lucky because there's so many opportunities, and we're all excited to see what happens next. So thanks again for your time.
Anyone? Maybe I could ask.
Oh, yes.
In the beginning, when you said to predict child abuse, you said 2%, half of all cases. But what's the false?
Excellent question. So I was rushing through the numbers. So the numbers are, of all the labeled outcomes, in other words, of the 20% of real child abuse cases that were actually detected by the system, right, those are the ones that actually have a diagnosis, right, so that's our gold standard, which is a very bad gold standard. Of those, we were able to identify about half at 95% specificity. Now the question is, what is the PPV? Because it's a rare event. So I can look up the table in the paper, but the PPVs end up being pretty low. They're not in the tens, they're maybe below 20% because of the rarity of the condition. So it's a classic kind of rare condition case. The use of this system, however, is very focused on a clinical workflow. All doctors in Massachusetts, for example, are required by law, they have a policeman's duty to report child abuse if they suspect it based on a clinical encounter. So they're required by law to do a screening. A recent study looked at how often, honestly, doctors were doing the screening, and the answer was about 10% of the time. Mm-hmm. So the thing they're required by law to do, they weren't doing. And so the question is, what is the cost of a false positive here? We pitched our system not as a decision support system, but as a screening support system. So we said, this system is going to go like this to the doctor anytime a person falls into a certain high-risk group. And the message that'll come out of the system will be, hey, doctor, you know that thing you're supposed to do for every patient, but you skip it most of the time? Don't skip that here. So the system is not going to say this person is a high risk for abuse. This says this person should not be skipped. which is a screening support system which kind of changes the numbers of what PPV is useful, etc. So, good question.
Appreciate it. Thanks.
Yeah.
Okay.
Okay, thank you.